Hi everyone, welcome to today's Student-Led Journal Club and Case Reports presentation. Today, student Dr. Rory Li is currently working at the University of Utah as a post-sophomore fellow in pathology, where he's also pursuing his master's in science. Prior to Utah, student Dr. Li had just finished up his second year in medical school at KCU, where he discovered an interest for pathology. At KCU, student Dr. Li worked as an anatomy lab tutor and volunteered at a COVID and flu vaccine clinic. He also worked on research with the anatomy fellows both years, submitting a poster with the fellows titled Investigation of a Novel Cranial Ligament Between the Occiput and Cervical Spinal Dura. Student Dr. Li is enjoying the beautiful Utah outdoors and is looking forward to visiting the national parks there. And with that, if you would like to start sharing your screen and begin your presentation, you can take it away.
Yeah, let me just start it right off real quick. Be able to see my screen?
Yep, looks good.
Yeah, so I have two case presentations today. These are, so during my first 2 months, I spent my first month on transfusion, and then second month on clinical chemistry before transitioning to anatomical pathology, where I'm in cytopath right now. So in July, I looked at a case in transfusion where we saw a case of DIC, and I kind of just want to go over it and how it was managed from the pathological standpoint. So I want to have so the objectives is we're kind of just going to do a case study, take a look at it, and I want to talk about kind of TTP versus DIC because it's that was a really challenging topic for me second year med school, and there's a lot of overlap between the two, and part of it will be how it's managed clinically as well, and I'll go over that later as well. So after that, I want to talk about the causes of TTP and DIC, how we detect TTP and DIC, and then how we treat it. So let's meet our patient first. So our patient is a 33-year-old female, and she had swelling of her left upper extremity, which was eventually diagnosed with a DVT of her left subclavian vein. A lymph node biopsy in her left neck shows poorly differentiated metastatic carcinoma, and on special histological stain, we had immunohistochemistry. She had a positive CK20, negative CK7. And so this usually tells us that, so CK7 and CK20 in are stains that are pretty useful in telling us kind of where something is located. So for example, like CK20, positive, CK20 negative, CK7 negative, usually I believe indicates, cancers of urothelial origin. So it doesn't tell you the type of cancer, but it can tell you where the primary site is. So it's a pretty powerful tool. So, and CK20 positive, CK7 negative is usually associated with carcinomas of colorectal origin. So eventually she was diagnosed with stage 4 adenocarcinoma of the cecum. So on admission, she had a peripheral blood smear that showed a frequent schistocytes and had a elevated total bilirubin at 5.8, virtually undetectable haptoglobin, elevated LDH, and her fibrinogen was normal at 418. So, so she called in to her primary care doctor, and she was urged to, come to the emergency department immediately because of how serious this nature was. So at that point, the top differential that we had in her was TTP. And so how we score TTP is using the PLASMIC score. And she got a score of 5, which is intermediate risk for TTP. And I'll just kind of go over the PLASMIC score. So it's scored out of 7 points. 0 to 4 is a low risk group. And 5 points is intermediate, and 6 to 7 points is high risk, and you can kind of see the percentages for each risk group. And I'll talk a little more about the ADAMTS13 deficiency and how that relates to TTP in just a few slides. But we calculated PLASMIC score, and this is what we this I believe is MD Calc, and this is what we kind of look at. So we look at her platelets, hemolysis, whether or not she has active cancer, if she's ever had a solid organ or stem cell transplant, the MCV, the INR, and the creatinine. And so these were inputted lab values onto MD Calc from her labs. And so you can see that she had a PLASMIC score of 5, which is an intermediate risk group, which gives her a 6% chance, risk of severe ADAM-TS13 deficiency. So kind of what do we do here? So we, in the emergency department, initiated her for of PLEX therapy for TTP. She had hemolysis, there was neurofibrinogen, she had a plasmic score of 5. So they gave her 2 units of packed red blood cells, and then therapeutic plasma exchange to start while we waited for results from her ADAM-TS13 test. So what does the ADAM-TS13 do? So it cleaves von Willebrand factor. So if you remember back, I guess first years haven't had it, but you'll learn eventually that von Willebrand factor needs to be cleaved, otherwise you can get clumping of platelets. So if you don't have the ADAM-TS13 enzyme, then you leave von Willebrand factor unchecked. So so under high stress, then that forms platelets thrombi. So in a normal person, an ADAM-TS13 level is at greater than 68%. And anything under 10%, we would see a high indicative of value for TTP. So then the question is, this patient had a 6% chance of having TTP, and from the transfusion standpoint, we think about what's the risk benefit analysis? Like, do we give the platelets to her? Because as you know, kind of right now in the United States, there's a shortage of blood products, so we're very conservative with how we handle giving out products. So for example, at the U right now, if any team needs more than 2 units of platelets, a resident gets a page and we kind of have to do some investigating. Usually we'll give it, but we are trying to prevent inappropriate usage of blood products due to the shortage. So then we have to investigate and think about, is it justified giving PLEX to this patient? So TTP has a high morbidity and mortality rate unless it's appropriate therapy is timely initiated. So really, it has a very low threshold for admission. So because of the clinical urgency, you need to just start giving her treatment before you can actually confirm the diagnosis with laboratory testing. And so, if you delay the PLEX treatment, plasma exchange, then that's one of the most major factors in adverse outcomes. So starting PLEX early, even before we know the results of her ADAM-TS13 results, is indicated at this point. So sometime later down the road, we get the results back from the lab, and the ADAM-TS13 result came back at 84%. Remember, the cutoff is usually 10% for TTP. But the lab also did a Coombs test, and so we did a Coombs test because we're testing for antibodies against red blood cells, because she does have elevated LDH along with schistocytes on peripheral blood smears. So after all this came back negative, then the clinical team starts to think about maybe this is actually DIC and not TTP. So next, we looked at the ISTH. We're going to take a look at the ISTH criteria, and this is the criteria used for DIC. It's scored out of 8 points, and 0 to 4 points is not suggestive of overt DIC. 5 to 8 is compatible with overt DIC. Remember, these are just kind of clinical guidelines. They're, it's totally possible for somebody with 4 points to be in DIC, and somebody with 5 points to not be in overt DIC. It's these are kind of just guidelines and not hard rules. So Well, we look at, what we look at um, for ISTH criteria for DIC, we look at the amount of platelets. We also look at kind of, the elevated levels of fibrin-related marker, such as D-dimer, and then whether they have a prolonged PT time and the fibrinogen level. So if you look here on the right, this is from ND Calc again, and this was we used the lab values to input kind of this to calculate a score, and which gave us a score of 7. So so this is compatible with overt DIC. We want to treat for DIC as appropriate. So before we kind of talk about how we treat DIC, so we have a couple of transfusion products. So there's the 4 major ones that we hand out in the blood bank are red blood cells, plasma, platelets, and cryoprecipitate. And so usually, the red blood cells are packaged in 300 milliliters packets, plasmas in 250, platelets are in approximately 300 milliliters in volume, and cryo is 15 to 20 milliliters. So, what do we do this for? So we have, so in each one, so red blood cells contain red blood cells, plasma, and anticoagulative preservatives. This is kind of just a chart that if you guys want, you guys can take a look at later time for people who are watching the recording. But this is kind of, a lot of people don't realize, what's in it in the blood products. And this is a chart that I use daily while on transfusion. So, and we can come back to this later, but really we use red blood cells, why we use them. So for massive hemorrhage or severe symptoms of anemia, plasma is used for DIC bleeding, TTP, MTP, which is a massive transfusion protocol. So when trauma happens, or other coagulation deficiencies. Platelets, this is actually kind of, you'll see a lot in common in clinic, is so for prophylaxis, we don't really want to give platelets to anyone if they have over 10,000 platelets. If they have, if their platelet value is 15, we're okay with that. It's actually, they'll be fine. If they're actively bleeding, we want to target for 50,000 or above. And for anything that's neurological, we want to make sure that our platelets are 100. And so, so my first day of work, I thought, I was like, man, platelets are at 20. That's really low. I think we need to fix it. But if they're not bleeding and, they don't have any surgical procedures indicated, 20,000 platelets is a fine number. And, in reality, neuro for 100,000, it would be fine at 50,000, but because, bleeding in the brain capsule, that's never a good thing. And because the lack of space, so we tend to trend higher and more on the side of caution for neuro. So that's why it's at 100,000. And then for cryoprecipitate, if they have hyperfibrogenic bleeding, when they're really missing like fibrin. So kind of to separate the difference between DIC and TTP. So why, this is a topic, that confuses a lot of people. So if you look for platelets, blood smears, and LDH, DIC and TTP both have very similar, profiles. You're going to have decreased platelets. You're going to see schistocytes on blood smears because of the, the thrombi that when red blood cells go past clumps of platelets, it's going to kind of tear them apart, distress. And you're going to have increased LDH, which is released from the red blood cells. But if you look at what's really different is, the PT-PTT values, the fibrinogen, and the D-dimer. In TTP, you're going to have normal values for all of these. While in DIC, you're going to have increased D-dimer, decreased fibrinogen, and increased PT-PTT times. And so the key difference here is that the DIC activates the coagulation cascade, while TTP doesn't. So DIC is consuming, all those factors. And I actually have a chart for that later that's stolen from Robbins. So one thing that we have to think about, so TTP is Thrombotic Microangiopathy, the TMAs. So it's kind of thrombosis, blood clots, and small vessels. So these are the three main ones that we think about. TTP, which is Adam's DS13 deficiency, STEC, HUS, which is a Shiga toxin from E. coli, and atypical HUS, which is a deficiency in the complement system. So when they have a TMA, these are the three biggest ones. So when we look at TTP versus DIC, in TTP, activation of the coagulation cascade is not of primary importance, and it's that fact that dictates like why we give only plasma therapy to patients in TTP. They're not missing any coagulation cascade factors. They're not missing we're not giving them fibrinogen because they're not missing fibrinogen. They're just missing the enzyme ADAMTS TS13, which is why we give them plasma. And so for PT and PTT test, they're going to be normal in lab tests in TTP, and that's because, again, we're not missing any coagulation factors. And another thing that's very important to think about is that DIC is typically not a primary disease. So it's usually acquired in multiple clinical scenarios. So think about cancer, think about sepsis, and think about pregnancy complications. Those are three of the bigger ones. And if we go back to our patient, she did have stage 4 adenocarcinoma, which is in line with cancer. So I found this really nice graph kind of about thrombocytopenia. And if you see kind of like you can kind of ignore everything else, but DIC and TMAs, which includes TTPs, there's some overlap in the middle. So it's kind of very easy to get them to think one can be the other. So how do we treat DIC? So we treat DIC by giving them kind of everything. So red blood cells, platelets, fresh frozen plasma, and cryoprecipitates. So we want to target, for red blood cells, we want to target 7 grams per deciliter. And I know that seems kind of low, but trust me, 7 is a really good target. Most of us, our hemoglobin levels were going to be a lot higher, but 7 is enough to function, as I discovered in July. Platelets, you want to target 50,000. For fresh frozen plasma, the point of it is to replace coagulation factors, but we really want to watch how much plasma we give people because of there's a danger for TACO. And TACO is transfusion associated circulatory overload. So it's relatively common at times. It's a transfusion reaction where you can get pulmonary edema because of volume excess or circulatory overload when you're giving them the products. And then the last thing that we want to give them is cryoprecipitate to replace the fibrinogen that's being consumed in DIC. So as I was talking about Robbins, so kind of this is the DIC activates the coagulation cascade. So that's why you give cryoprecipitate along with plasma to try to replace the fibrinogen and kind of all the other factors in here. And that's why you also get decreased in TP times and TPP times, because you're consuming factors from both the intrinsic and extrinsic pathway compared to TTP where you're not. So, what's a good level of fibrinogen levels in DIC? Because you don't want, normally it's recommended for about 100 milligrams per deciliter, and some sources recommend 150 milligrams per deciliter. But really, I think from just kind of looking at it, 100 milligrams per deciliter is what the literature usually says. But you have to remember that like kind of the levels are dynamic and they fluctuate all the time because it's constantly being replenished and used up. So you want to just target about 100 milligrams per deciliter. And that is kind of my references for this one. Does anyone have any questions about DIC and transfusion? No, and then so I actually have another talk prepared as well, and I'll get that on the road. So the other thing that I want to talk about today is kind of HIV testing and how it's done, kind of the process. It's more laboratory based. You know, at ARUP here, we're a national reference laboratory, so we can process all this in house. So we get a lot of clients from across the nation. So so what is the indication for HIV testing? What's the algorithm and how it's done, and when do we use it? So we're gonna review 2 cases of HIV testing. So during my month of ClinChem, we clinical chemistry, we kind of have a phone area where since we provide services to so many hospitals across the nation with lab tests, we have people on staff, the residents, who sit there and field questions from clinical teams across the United States to the hospitals that that use us for their laboratory testing, and we kind of answer their questions about what do these tests mean, and if they have any questions. So it's kind of like the questions get asked, and then we kind of try to find answers for them and try to provide it. So these are both cases are things I saw during my month there. I actually had 3 calls about HIV testing, and this is kind of just two of the cases that I saw. So I'm going to review 2 cases of HIV testing. We're going to try to identify the correct tests to order. We're going to learn about the methodology for the test, and then we'll kind of loop back and discuss what should have been ordered for each patient. So case 1. So we have a 22-year-old female, and they ordered a Hep B surface antigen, a Hep C virus antibody, and a HIV 1-2 combo antigen antibody test ordered. So both the Hep B and Hep C tests came back as negative, but the HIV 1-2 combo antigen antibody test came back as reactive. So then they ordered the HIV 1-2 antibody differentiation immunoassay. And for HIV V1 and 2 antibodies, they came back as negative. So 9 days later, they reordered the same test, the combo antigen antibody reactive, differentiation immunoassay, both negative for HIV 1 and 2 antibodies. So the question that was proposed to us was, what are we supposed to do? Does our patient have HIV? And we'll get to the answer later. The second case that we got was a 46-year-old male. They got antibody differentiation immunoassay, where 1 and 2 HIV 1 and HIV 2 antibodies came back as negative. And then they did HIV by quantitative NAAT, which came back as negative. So the question that the clinician posed to us was, what's next? Does this patient have HIV? So we'll talk about, what was missed in cases 1 and 2, and kind of where they misordered the cases, and what should have been done, and to manage HIV testing in patients. So taking a quick look, this is the HIV structure, and one of the things that we test for in the 4th gen immunoassay, which is the differentiation assay, that's going the HIV 1-2 combo is the P24, which is the core protein structure. So it's right here. So for those of you, I'm not sure if we've learned this in 2nd year yet. The 2nd years have learned it yet, but we have this beautiful flow chart that that I saw last year that was taught to me. So we have the antigen antibody immunoassay up here. That is the 4th, right now, that's the 4th generation test, the combo. So we can kind of follow through this. So if it's negative, then we can say that they don't have HIV 1-2 antibodies and a P24 antigen. In most cases, they're there are some exceptions. There's one exception to the rule, which I'll talk about in a second. And if they're positive, then we want to go down. We want to figure out, hey, what type of antibody is positive? So, whether it's HIV-1, HIV-2, or HIV-1 and 2, or maybe it's in both are negative and both are indeterminate, in which case we would go down to the nucleic acid testing for HIV-1 but not HIV-2, and we'll talk about that towards the end, why we don't do HIV-2 testing. So circling back to this, so if it's negative, if the combo immunoassay, the 4th gen test is negative, your client most likely doesn't have HIV, except in a case where they had recent exposure that they're concerned about. And we'll talk about why, on the next slide, kind of why, if they have concerns for a recent infection, you can't rely on this test as a negative test to confirm it. So we have detection time. So, so right now we're using the 4th generation immunoassays, and they can detect infection about 5 to 7 days faster than the 3rd generation. And the main difference between the 4th and the 3rd generation is really just the P24 protein, the P24 antigen. So you can kind of see here, the days elapsed. So with viral nucleic acid tests, we can detect it in about day 10. It's about day 18 for the 4th generation immunoassay, the P24 core protein. And then with kind of just antibodies, it takes about 22 days, 23 days to detect it. So looking at the detection times, so the 4th generation test detects HIV about 18 to 45 days after infection. Well, the antibody only test requires about 23 to 90 days to yield reliable results. And the nucleic acid test can identify HIV 10 to 33 days after an infection. So, so there's this window period right here where, if we have, where we might have a negative result and we think they're fine, but in reality, they haven't built any antibodies to HIV yet. So that's why it's recommended to do the, back on the flowchart here, if it's indeterminate, we don't see any antibodies yet, but we see the P24 antigen, then that's why we need to do the nucleic acid test, because it takes this 23 days to form antibodies on average, potentially even longer. It could take up to 90 days. Well, the nucleic acid test, we can see it in as soon as 10 days. So that's why we do that. So let's talk about the 3 tests. So the first one is the combo HIV-1/2 antigen antibody immunoassay, also known as the 4th gen test, and I'll just refer to it as the 4th gen test from now on. So there's the 3 things that we look for are the P24 antigen for HIV-1, HIV-1 antibody, and HIV-2 antibodies. And it has a sensitivity of 99.7%, specificity of 99.3%. And the key thing to remember here is that we can't distinguish between the presence of whether it's a HIV-1 antibody, a HIV-2 antibody, or a P24 antigen. It just tells us something's there. It doesn't tell us which one, which is why we need to do further testing after this. So if this is negative, the 4th gen test is negative, the person is considered not infected with HIV if and only if there's no recent exposure has occurred. So how do we detect this? So we use, so now we're going to kind of go into the lab techniques, the qualitative chemiluminescent immunoassay. So we have a well here that contains P24 capture antibody and HIV and 1 and 2 recombinant proteins. So we add an unknown patient sample to the well. And then, so P24 antigen binds to the capture antibody, and the anti-HIV IgGs and IgMs would bind to the recombinant proteins at the bottom of the well. So we would incubate and wash to get rid of anything that's unbound. And then we would add antibodies that would bind to the P24 antigen or the FC region, the constant region on the anti-HIV IgG and IgMs. And then we would wash it. So this is what it would look like. So here's our HIV antigen. So here's our antibody that from the patient sample that attaches to it. We find another antibody that binds to the constant region here. And when we add a chemical reaction to it, we have an enzyme here that will light up and we can detect a color change. So that tells us something is present, because if the patient doesn't have any HIV antibodies, then this, when we wash it off, none of this will stick and we won't get any color change. So if light is detected, then you know that there's P24 antigen or anti-HIV antibody present, but you don't know what's present. So we would have to go on to the next test to see what's there. So the next test that we order in sequence is the HIV 1-2 differentiation immunoassay. And we'd order this when the first test is positive, and we want to differentiate whether the infection is HIV-1, HIV-2, or potentially both. And if HIV-1 and HIV-2, the differentiation assay is negative or indeterminate, then we would move on to the nucleic acid test. So for the second test, we use a method called qualitative immunoassay. So this is a lab test that ARUP does. I'm sure that a lot of other labs do it, but this is found from our website and the methodology here. So we have cassettes that contain antibody binding protein A, kind of bound here. And then when we add samples and buffer to the well, the specimen reagents will flow onto the test strip, and it will bind, you'll have the binding of the antibody to the antigen. So the antibodies bound onto the antigens, and then we use protein A colloidal gold, which binds onto the captured antibodies, and on a strip will develop pink and purple bands. And so we actually use a machine to read the bands, and it tells you what is present or not. So I don't actually have an example of that. I wish I had a photo, but I don't. But if there's no HIV antibodies detected in the sample, then we won't see any bands on the cassette, and the machine will say, oh, it's negative. So, but if it is positive, then we know what we have. But if it is negative, then we have to continue on with our test. And the third test that we have is the HIV-1 by qualitative nucleic acid amplification test. So we use it to detect HIV-1 RNA quantitatively, and it has a specificity of 99.4%. If it's positive, we have an acute HIV-1 infection. If it's negative, they don't have HIV-1. So for this, we use quantitative transcription mediated amplification. It's like basically PCR. And so what happens is that we have kind of a RNA, the RNA virus right here, the RNA target, and we attach a promoter primer to it, and we synthesize complementary strand of DNA via reverse transcriptase. And then we can remove the RNA template, add a second primer to our DNA, and then elongate that strand to create a complementary pair to the other strand that we created using reverse transcriptase. So now we turned our RNA target into a strand of DNA. So we would then use RNA polymerase to make hundreds or thousands of RNA transcripts, and then we would kind of rinse and repeat the process. Put a primer onto the RNA, make a copy of copy DNA using reverse transcriptase, remove the RNA template, add another primer, and then create a double-strand DNA. So this is to kind of amplify it. So, so then, knowing how many cycles that we went through, we can kind of go back and work to see how much RNA was in the original sample, and from there we can determine whether it was a positive test or a negative test. So kind of going back to this. So this is kind of the algorithm that's used, and this I'm sure you'll see in third and fourth years, and family practice, and maybe even the emergency room. We'll kind of see this kind of the how to order a test for HIV, the algorithm. So let's take a look back at our cases now that we've talked about them. So HIV 1-2 combo, the 4th gen test was reactive, and then the differentiation immunoassay was negative, and they were done twice, 9 days apart. So what do we do next? Does this patient have HIV? And so the HIV 1-2 antibody differentiation immunoassay could be negative due to the window period. Remember, it takes about 23 to 90 days to get a result from antibodies. So 9 days apart, it could totally be still in the window period, and we don't have any antibodies. So the patient has to mount the immune response first if we were to detect that antibody. So for us, we recommended that the next step is to confirm with a nucleic acid amplification test to confirm that diagnosis, because we can detect that 10 days, at the minimum, to about 33 days. That's usually the window where we can detect it for using a nucleic acid test. So if this was a false positive test, then our nucleic acid amplification test would be negative. But if not, if it's positive, then that means that this person is very early in infection, because from what we've seen here is that we've detected P24, but there's no antibodies yet. So for case 2, the patient ordered, we got HIV 1-2 antibody differentiation immunoassay, and both are negative. And then so at ARUP here, there's so many different test codes. One of the codes for this is that when this is negative, it automatically reflexes to HIV by quantitative NAAT. So you don't have to order it. If this is negative, it'll automatically run this test itself. So that also came back as negative. So then the question becomes, does this patient have HIV? So the client mentioned to us in kind of the phone call that they had a very low suspicion for HIV, but they wanted confirmation for it. And so, given that their nucleic acid test was negative, then we were pretty confident in telling them that no, their patient did not have HIV. But what should have been done here? We also told them that they should order a 4th gen screening test at their own lab. And so the question is, why didn't we order one at our lab here? Well, when outside clients come to us and ask for antibody differentiation immunoassay, we assume that there's a positive 4th gen screen at their lab. So that's why we just run it directly. We assumed there was already a positive 4th gen test, but they didn't do that at their lab. So we told them for the future reference that they should do the screening test first before doing the antibody differentiation test. So, and then we assured the client that their patient is most likely negative for HIV. So that brings us to the question about HIV 2. So we have a HIV 1 nucleic acid amplification test, but we don't have one for HIV 2 here at ARUP. And so the reason behind that is that a significant percent of individuals with HIV 2, they have undetectable HIV 2 RNA levels. So even if we try to run a nucleic acid test, it won't be detectable. So a positive HIV 2 antibody test on the differentiation assay should be considered positive, even if we don't have plasma HIV 2 RNA that's able to be detected. And HIV-2 is actually kind of a lower prevalence in the United States, so you don't see it as much here. So that's kind of, the backbone of the reason why we don't really do HIV-2 nucleic acid testing here. We do it for just the first one. With that, do we have any questions? I saw Dr. Steininger had a question. These are my references, and then I'll go see Dr. Steininger's question real quick. What did you say? It's very hard to interpret a negative result. It's
as long as you have a positive control for the assay, you're in good shape. Because especially in PCR doesn't work. It could be that the person running it didn't do it right, or
right.
It's just very important to have positive controls all the way around.
It is. And actually at kind of an ARUP here, so we actually have a histology department that stains our H&E slides for surgical path tissue. And on every stain that we order, when they cut the tissue, they draw a line down the middle of the slide and they put a control piece of tissue. So if there's, from tissue that we acquire from autopsies or whatever. So if we know that, for example, for breast cancer, we care about like ER and PR. So they actually have known tissues that's ER positive on one side, and that's a control. And we look at our tissue on the other side, and we determine, what % of it is stains ER positive or PR positive, and we actually have to dictate, on a sheet whether it passes the control or not. So, and that's, that's with every single stain at the immunohistochemistry stain, chemical stain here at ARUP, and there's like hundreds of them.
That makes absolute sense to me, because if you play with antibodies long enough in an antibody in a lab, you can pretty much get any answer you want, depending on protein loading or detection time, or you can mess with anything. So especially in a pathology lab, when people's lives are in the balance, I'm sure those controls are incredibly, you pay a lot of attention to those.
Right, yeah, so you do. Like, we have to look at the control every single time and make sure that it's positive, and if it doesn't pass, then they have to recut and restain a slide on a control that actually passes. So that's kind of the gold standard here, I'm sure, at every lab. So,
a broader question: how are you enjoying your experience in Utah? I mean, it's got to be amazing, I would think. But let's hear from you.
Yeah, I love it. I think it's definitely a lot different than KCU, just in terms of how things function. Because I'm at a larger academic research institution. We have about 100 and I think like 40 plus pathologists on staff here. So we kind of get experts in every single field, and it's it's just really cool to be able to get to work with patients and see how like pathology kind of has firsthand care, and really pathology is so inclusive with everything. Like we have these TPCs, tumor planning conferences, where kind of surgery and pathology and radiology, and a bunch of other specialties, we get together and we over in a Zoom room and we talk about like what's the best way to approach this tumor, what should we do, are they a viable surgical candidate, kind of. So it's really inclusive. And I've discovered that it's while we don't see the patients ourselves, unless you're on cytopathology, we actually go in person to the patients. But while we don't see the patients ourselves, kind of like everything that we do has large ramifications in terms of how patients are managed clinically. Whether something is for breast cancer, whether ER, PR, and HER2 is positive, negative, all of that is very important. How the cancer is managed. So, and then in cytopathology, it's hard to get. We want to make sure that we have adequate tissue for kind of a diagnosis. So the fellow that I work with compares, says that cytopathology is like the emergency room of pathology. We kind of go around to different places with literally a microscope on a cart, and that we wheel around the hospital. It's quite a sight to see, but we go around and they take core biopsies of liver, of lymph nodes, and we kind of stain it right there and then and tell them whether we have enough material to kind of enough sample to do an accurate diagnosis and get all the stains that we need. So instead of them having to undergo CT, anesthesia, and then getting a biopsy, only to be like, well, the tissue is inadequate. And that's happened quite a bit. I think today there's 2 cases where it's like they're here for rebiopsy, because the first 2 cases we read out, when cytopath was not consulted, it was inadequate, unsatisfactory for interpretation.
My goodness. So it sounds like what you're learning is the real importance of teamwork. And
right.
Moreover, to me, I was in the lab when you were in here, when you learned of receiving this fellowship or whatever it is you're doing. Sounds like a fellowship to me. But what I'm going to say now is to all students in the room, and that is, you never know unless you try. Reach for the stars, and you'll never be disappointed when it comes back positive or negative. I'm watching you right now, and you're filling my heart with joy, having had this experience and bringing it back to KCU through this Zoom meeting. Thank you so much for doing that, Rory.
Yeah, of course. Anytime, Dr. Salinger. And for, anyone that's I guess, maybe interested in pathology, feel free to talk to me. I think that, path is really cool, and I think a lot of people overshadow it, but, I think that it's super vital in understanding how things work and how things run, and how things are managed clinically. It's all, it's all behind the scenes work. And for people who think all we do is sit in a desk in a basement with a microscope, I will counterclaim the fact that we actually are on a mountain in Utah. We're on the 3rd floor. We overview all the mountains and the entire city, and it's very beautiful. And I also walk 10 miles a day on cytopath. So it's not just all desk work. There's a lot of fun. Does Dr. Kramer have a question? He has his hand raised.
He does.
He does. Can you hear me okay?
Yeah.
Welcome back to KCU.
Thanks.
First of all. So this question is more philosophical, if you will, but being inundated in a world of ELISA and PCR, and the fact that we're going through a pandemic right now in which testing is quite critical. What are your thoughts on rapid tests, especially in the world of ELISA? So, there's several that are used routinely
Right.
in everyday life. Pregnancy test, for instance, and now these rapid COVID tests, which have some accuracy associated with them, and obviously, accuracy is of utmost importance in the clinical setting like you're doing. However, it seems to me that in some cases, not necessarily what you presented today, but in some cases, rapid testing of other pathogens or other diseases may be beneficial. However, there are drawbacks to that. What's the kind of the chatter in the pathology world for these rapid tests?
Yeah,
Long question for a short question.
Yeah, there's a lot. At ARUP, we develop a lot of our own assays sometimes. Kind of things that are only here. So one of our pathologists here actually developed a model of the serotonin release assay, here at ARUP, and kind of we were just talking about that. But with any of these tests before they go through, I think she went through 700 pages of validation for the results before we actually started using it. So I think there's benefits to it, but with any test there is going to be false positives, and so we have to use, I guess, the results cautiously, and and correlate everything clinically. I know people hate that saying, but you really do. It's the labs tell one part of the story, but there's a lot of things. Labs aren't necessarily 100% accurate every single time. So I'm not sure what the what other rapid tests are being kind of developed here, but there's a huge research department here that's just dedicated to kind of developing tests and trying to make our products better. Not sure if that answers your question completely.
I don't know that there's a complete answer to my question. It was more of just a general idea of these rapid tests versus a more thorough, if you will, say ELISA. And Dr. Staudiger's question or point was about the negative controls or the negative results being hard to interpret, and that's always going to be part of testing, like you said, with false positives as well. So.
Right. Yeah. I'm not really sure about that. I don't spend too much time in the lab. I don't have control over, how I don't actually get to see how the tests are done and everything. I kind of just sit there and interpret them. Does anyone else have any questions or anything they want to learn about or know?
I have a question.
Yeah, go for it.
Yeah, so you're talking about the sensitivity and specificity of tests. I was wondering, in the event that one of these tests are that event where you get the result and it's it's like one of those errors that the test has, and where it's not identifying the right scenario. So what happens if you use that test and it says that it's negative, but then you go to the patient and you tell that patient he doesn't have a disease, the disease that you're testing for, but it turns out that test was actually wrong. What do you do when that patient has those negative outcomes? How do you handle it from there?
Yeah, so that's a good question. It's pretty complex. So I work on the pathology side, so we kind of tell clinicians. We don't actually have any face-to-face interaction with the patients and all their lab results. So we wouldn't actually be telling the patients about about the outcomes. It's more we talk with more of their the care team, the nurse practitioners, the PAs, the nurses, the doctors. But it's and we really haven't had that happen. We have kind of very strict guidelines and protocols here at ARUP, and in terms of just the quality of testing and the standard. So we're actually so most labs we are actually approved by the New York State, because we do lab testing for clients in New York, which is stricter than federal guidelines. But we also have we're also I think it's ISO 15189 approved. So yeah, I'm not really sure kind of what happens if that happens, because we usually don't handle those situations as at the spot I'm in. We do have lab directors and we call them medical directors, who are pathologists who are more involved in those cases where things kind of go awry.
Yeah, I guess it was just more of a general question, but yeah, thanks for answering.
Yeah, and it does happen, but I usually don't see that happening, and if it does happen, it's pretty rare. But for us here at ARUP, if a client has any kind of doubt about the validity of the results or whether it's possible or not, we will rerun the samples at no charge to the client in order to double check that what we actually got is a true result and not a false result. Even if they have to send another sample or something, well we'll usually run those.
Well, thank you so much again, student Dr. Li. That was a really good, both of those presentations were really great, and I appreciate your time and interest in presenting.
Yeah, thanks so much for having me.